So liver is a very large gland, the largest gland in the human body except the brain. And it's an organ which is derived from the primitive gastrointestinal tube. It's localized in space below the diaphragm on the right side, but partially it's shifted also to the left side, and in some individuals also left lobe could be on the left subphrenic space. So subphrenic space is the prime localization of a liver, and mainly on the right side. Around the liver there are spaces which are part of a peritoneal cavity, and those are recessus subdiaphragmaticus, so recess which is between liver and diaphragm, and also the second space which is dorsally between a kidney localized in retroperitoneal space and liver, and there is a recessus which is called hepatorenal or hepatorenal space, also enlayered by peritoneum. And the third space, which is the space between the stomach or below stomach and below liver, is called omental bursa or bursa omentalis. So those are three spaces which are surrounding liver tissue, and liver tissue is covered mainly by peritoneal coverage, with some small exception. So liver position then is on the transversal section here seen. This is the liver, and here liver. The liver is the organ of GIT gland, GIT external gland, which is localized and developed in so-called ventral mesentery. Ventral mesentery is the attachment of the primitive gastrointestinal tube to the anterior wall, and the rest of this are these two structures. Those are structures. This is ligamentum falciforme, falciform ligament, and here the second, the ligamentous structure, which is called omentum minus. Or lesser omentum. So this is liver, and liver is then covered mainly by peritoneal enlayering, which is seen here. Only small part, which is around the inferior vena cava, there is no peritoneal coverage, and this part of liver is called area nuda, so the bare or nude area. Nude because there is no peritoneal coverage, and the surface of the liver is directly continuous to connective tissue, and there is the attachment to the posterior and apical part of a diaphragm. So liver, in Latin hepar, could be divided in some sectors. This is the view which is from below and dorsal. So here we have a right and here left part of a liver. We can distinguish here fissures, grooves, which are localized in vertical orientation. One shallower and larger groove is called fissura sagittalis dextra, or right sagittal fissure, and it's containing groove for inferior vena cava and gallbladder. The second is a fissure which is called left, and here there are two remnants of the embryonal development. Those are ligamentum venosum, so venous ligament, this one, venous ligament. This is a remnant of ductus venosus, the connection between the umbilical vein and the right hepatic vein, which is the bypass for the blood enriched by oxygen, which is bypassing liver in a fetus directly from placenta to the circulation in the heart. The second ligament here is ligament which is called ligamentum teres, and the ligamentum teres is a rest of the own umbilical vein. This is a rounded ligament, and it is then connected to the umbilicus or umbilical scare. This is very important because in some special occasions in portal hypertension there is the possibility that this vein again become B-vein and it's recanalized and the blood then could flow outside from the liver through this structure. So in a central part we have some bridge, so then those grooves forming H letter, the transversal bridge of H is a porta hepatis. Porta structures there are from right to left. So this is gall way, then artery, and then porta vein. So those are three structures which are called portal triad. Bile duct, artery, the branch or the own proper hepatic artery, and the vein which is portal vein, or in Latin vena portae hepatis. This vein is leading blood from the gastrointestinal tube towards to the liver. So those two vascular structures flowing into the liver and backwards only bile in the bile duct. So then when we have this H structure here, then we are able to distinguish four general anatomical lobes. Those four lobes are called right, left, quadrate, and caudate. Lobus dexter, sinister, caudatus. Caudatus called because it looks like here tail going to the inferior vena cava, and quadrate because it has quadrate shape. So those are main divisions of a liver parenchyma. So now I have to say once again the portal structures. The portal structures, this triad, is made from arteries. The artery which is supplying liver is a way from celiac trunk. Then here we have a common hepatic artery, and from common hepatic artery the proper hepatic artery starts when gastroduodenal artery arising. So this is the O. Then this is the artery which is going into the liver parenchyma. In the same time, here dorsally you can see porta vein which unites from splenic and superior mesenteric vein, and this blood is flowing into the liver parenchyma. The bile ducts, and we will have bile ducts anatomy today, are taking the bile from liver, and the bile is conducted then to the gastrointestinal tract. The veins, which are called hepatic veins, are veins which are collecting blood which has perfused liver parenchyma, and this blood is flowing into the inferior vena cava, and then this is entering the systemic circulation. So portal circulation is a venous circulation between gastrointestinal tube and liver, and it's provided by portal vein. So this is a functional, important functional system. Nutritive system is made by hepatic proper artery. So in the structure of a liver, you will have multiple times in the future in other specialties, especially in histology and physiology. And then also very important thing is that you will note this structure in pathology, because there are too many points, critical points where could occur some pathological situations. For our purposes, it's important that the first unit is a lobulus hepatis. Lobule. This is hexagonal prism which has a central point which is called vena centralis, central vein. Central vein is a part of a hepatic vein system. So this is the outflow tract of this. This is in a central part. Then we have there 6 points around, which are made by tracts. Those tracts we know: hepatic artery, bile duct, and portal vein branch. So this is the main principle. The blood is flowing from the periphery, from the hexagonal point, to the central point, very central vein, and filling those spaces, which are called hepatobiliary spaces, and there are mixed blood from hepatic artery, proper hepatic artery, and portal vein. Then here, those trabecula, which are made from hepatocytes, working. They're working that they are able to create some important substances like coagulation factors, because it is a proteosynthesis. This is one of the most important things in the liver parenchyma. And then on the other side, they are creating bile. Bile is created and then excreted to the intracellular spaces, which are called capillaries, biliary capillaries. So we have too many nomenclatures. The anatomical lobulus is hexagonal with a central vein and peripheral portal triads. But we have a functional, so this is a portal lobulus which is triangular between three central veins. So those are microstructural things. On a macrostructures, we have lobes. I have said that we have a dexter, right lobe, left lobe, and here we have a quadrate. Quadrate is seen also on the surface, but it is not divided by the outside structure on the anterior surface of the liver, and here is caudate. Here, when you look at the liver, the first marker how to divide left and right is an interlobar fissure, which is made by ligamentum falciform ligament. Yeah, but the division of a liver parenchyma is too rough. This is an improper relation of the volume of those lobes. The largest one is the right lobe, the smallest caudate. But we have some functional anatomy. The functional anatomy means that we have functional units which are called liver segments. Sometimes they are called subsegments. The segmental orientation, segmental classification could be different. We use European, made by Cuinon, by French surgeon. But there is some Japanese classification, some American. They have roughly, relatively the same, but a little differences. So when you will work in the future in US, you will need to know the American nomenclature. But the European is that we have two important ways how to dissect liver parenchyma. One is horizontal. Horizontal is in the plane, or roughly the plane of the port-vein bifurcation. And the second are three planes which are along the plane of liver veins, so those systemic veins. Then we have dissected liver parenchyma in four sectors and two halves, upper and lower. Those sectors then named here, and they are here. So first segment is a caudate. Then we have a superior and inferior left. Then we have a fourth, which is quadrate. So nicely, you can see quadrate 4. It has upper and lower, A and B subdivision. And then we have anterior medial 5, anterior. Then we have 6, which is dorsal, lower, 7 and 8. What is important to know the numbers, not directly the names. So posterior medial, posterior lateral, 7, 8. Posterior inferior, posterior medial, 6 and 5. This segmentation of a liver parenchyma is important in surgery because there are units which are possible to be resected without targeting the bile leakage, bleeding, etc., etc. And the surgeon is able to perform dissection of a liver parenchyma here safely or almost safely. Porta hepatis. Porta hepatis contains porta triad, and it contains biliary duct, propria hepatic artery, porta hepatis. Those structures enter and also leaving parenchyma. And we had vessels, and now we have bile ducts. Bile ducts are on several levels. Inside the liver, we have capillaries. Capillaries, they don't have their own wall. They are only spaces, tubular spaces between two small hepatocytes. Then they are collected into the interlobular ducts, and from interlobular ducts we can observe the wall. And the wall of the bile duct contains fibrous and muscular layers, and inside there is a mucosa. The liver has production of proteins released to the blood, and then there is bile. Bile is an imparnous fluid which is called bile, bilis, fel, and it's excrete and secrete together. What is secrete? Secrete is something which it's containing something to be useful further. Here, what is useful? Useful are bile acids, which are used for emulgation of fatty substances in content of gastrointestinal tract, so in the intestine. Then there is important excrete. Pure excrete is, for example, urine. And here excrete, so we here have some waste products of metabolism which are excreted from a human body through the gastrointestinal tract. They are products of decay of hemoglobin, so bilirubin and cholesterol. So bile acids are part of secrete, and cholesterol and bilirubin excrete. It's 1 liter about a day, the production of the whole liver. And then the bile is flowing through the segmental to the 2 main ducts, which are called dexter and sinister, right and left. From right and left bile duct, we talking about extrahepatic. Extrahepatic ducts are outside the liver, and they are forming the way which is leading bile through the communication between gastrointestinal tube and liver, and this communication is called gastroduodenal ligament, in which we have all those structures of porta triad also. Porta vein, the stem, and proper hepatic artery, the stem, and the bile duct. So those bile ducts are then connected together here in this point, and in this point we start the section which is called ductus hepaticus communis, common hepatic duct. Then we have a side duct which is useful for 2 directions. There's a way to gallbladder, and also back if the bile is needed for digestion. This blind way then delineates the last part of extrahepatic ducts, which is called choledochus. Choledochus duct. And from choledochus duct, the bile is flowing into the duodenum. Hoping that you have heard about the papilla major and minor, so major and small papilla, where we have the communication between external glands of GIT with the inner space of GIT. So this is the imaging which is called ERCP, endoscopic retrograde cholangiopancreatography, which inject contrast agent backwards. But here you can see segmental bile ducts, right and left main junction, epsilon-like. Here, common hepatic duct, cystic duct, and this is a choledochus. And here we have a duodenum. Important is also this small thing will be noted on next images. Vesica gallbladder. It's a hollow organ which is like a sac forming a space for a bile duct, and the bile here is going resorption of the water, so there's more dense, more dark, and then the water from bile is resorbed by the mucosa. Mucosa has this reticular formation, and then from the sac, the bile could backwards be ejected to the hepatic, to the choledochus. So it has a column, neck, trunk or corpus, and a fundus. Due to over-resorption, sometimes over-resorption of the water in the biliary system could occur crystallization of some of those substances dissolved in the bile, like biliary stones. They could be made from bilirubin or cholesterol both together. The supply of the gallbladder is important. The supply is by one artery typically arising from the right branch of a proper hepatic artery. The knowledge of the supply is important in the cases when the patient is undergoing one of the most frequent surgical procedures in the abdomen, and this is a cholecystectomy, today made by the laparoscopic way. Laparoscopy is seen here. This is a gallbladder, and here cystic duct and cystic artery. You can see it here. Those structures should be ligated by a surgeon before removal of a biliary gallbladder. So those are liver and then bile ducts. Now we turn to the third important structure connected to this. It is the pancreas. Pancreas is a relatively large gland localized primarily in retroperitoneum. It's localized in the duodenal window. Duodenal window is a C-like structure, and in the C is localized the head of a pancreas. And the tail and the neck are lying along the second structure, vasa linealis, lienal vessels. So this is a localization of pancreas. It's localized in the midline and on the left side. The pancreas is divided in two important embryological parts. One is called ventral and the second is called caudal, dorsal. The paradoxical is that the pancreas is developing in a primitive GIT tube. One part is in the anterior mesentery, the second part in dorsal mesentery, and the anterior part, which is ventral, is rotating the way that finally it takes a place more dorsal. So when we're talking about dorsal part of a pancreas in situ, so in real anatomic situation, we're talking about the embryonic ventral. And this is important structure which is called processus uncinatus. So we here have pancreas. Pancreas is like St. Nicholas stick or bishop stick. Yeah. Here we have a head. Here we have a neck. Here we have a body, and here is a tail, an apex of a tail. This is a groove or incisura, and the head has a process which is called uncinate, because it's like a hook. And this uncinate is originally ventral, but in reality dorsally localized pancreatic tissue. It's a little bit different. It has a little different functions, and little different density of some receptors, for example, somatostatin receptors, more than the dorsal part. The anatomy of pancreas, gross anatomy, is very, very simple. Here we have one very important relation. I have said that the pancreas is lying in the C-like duodenal window and along lienal vessels. Then lienal vessels are localized in transverse orientation. In longitudinal orientation we have mesenteric vessels, mesenteric superior vessels. More right is vein, and more left is the artery. So then we have the simple example. When we have a tumor which is growing here in the head of pancreas, the most frequent site of pancreatic cancer. Probably you have heard that pancreatic cancer is one of the most rapidly growing part of oncology in the US, also in Western Europe, also in our countries, increasing number of those patients. The cancer then is infiltrating very early the vein. And when the vein is infiltrated, it's not completely lost case, because the surgeon is able to resect it or to ligate it. When the tumor then is growing towards to the mesenteric artery, then the surgical resection is improper way to treat the patient, because the resection is not successful to remove the tumor. So remember that in incisura, first vessel is vein, and there is a way how the blood is flowing into the liver, and the second line vessel is artery. So this pancreatic development, I have said that we have on the primitive tube two localizations. Here is one, here is a second, and the ventral is rotating this way that it is then dorsal. Because of this complicated development, we have two main ducts which are conducting the juice from pancreas to the gastrointestinal tube, to the duodenum. One way is a stride, the second is stride, but only during development. This one stride, smaller stride, is the longer and is from tail. This is a real dorsal pancreas. And it's going to the papilla minor. The original ventral is a lower papilla, and here you have a common duct for dorsal pancreas and for choledochus, for bile duct and pancreatic duct. And this is papilla major. But the problem is that there are some possibilities how to connect those two systems, and the variability is quite frequent and complicated. But the important thing is that the major papilla contains the supply by bile duct and pancreatic duct ever. So then this is a ductus pancreaticus major, also called Wirsungii, major pancreatic duct, and ductus pancreaticus minor, smaller, called Santorini. So those two pancreatic things are complicated, but there are some schematic frequent things. This is relatively common, and this is common. This is the last common, and this is the least common. But all of those are probable. So remember that we have a bridge, and the combination of that are possible. So about the inner structure, pancreas is a gland which has part with exocrine tissue, and then second which has endocrine. Exocrine, they are aciary cells, and those aciary cells producing enzymes, amylase, trypsin, and lipase. So amylase is for glycids, trypsin for proteins, and lipase for lipids. And also important is excretion of HCO3 ion. What is it? And what's the function of it? Could you tell me, one of you? Yeah? So it's a bicarbonate, and it's useful for which? Yes, very well. CO2 is a final product. One, it is with hydrochloric acid neutralization. So it's really neutralization of hydrochloric acid arising from cells in gastric space. So then the production of those substances, which are important for digestion, important for neutralization, so for safety of the GI tube, is guided by hormonal interaction, and those hormones are cholecystokinin, pancreasamine, and secretin, and they are products of gastrointestinal tube. The second part of pancreas are forming so-called and very well-known Langerhans islands. Those Langerhans islands contain neuroendocrine, so neural crest originating cells, which are producing hormones. For you hoping very well known insulin, and probably now gastrin, and following other. Those two are the most important, insulin and gastrin. It's insulin by beta cells, by delta cells, gastrin. Insulin is a hormone which improves intake of glucose, intake of glucose by cells everywhere, or almost everywhere. And gastrin is a hormone which is increasing production of HCl after digestion of food. So those endocrine parts of pancreas are richly vascularized, and then they are a little bit something different, and the diseases affecting pancreas could affect both parts or only endocrine. Endocrine cells could because of some neoplastic changes, and we're talking about insulinomas, which are overproducing insulin, gastrinoma, gastrin, and leading to hypoglycemia or to multiple severe gastric ulcers. The third important organ is spleen. So liver and bile ducts, pancreas, spleen. 3 abdominal solid organs. All of them are derived from gastrointestinal tube primitive. Lymph tissue, you know that we have a lymphatic tissue originated from GIT in throat and oropharynx, nasopharynx. And also probably you have heard in GIT that we have some folliculi aggregati or folliculi solitari in a small intestine. Spleen is a large lymphatic organ which has some ovoid shape and is localized on the left side below diaphragm. similarly to liver on the right side. It has a face facing diaphragm, so facies diaphragmatica, between ribs 9 to 11, and then the face facing, this is this face, visceral face, facing stomach, facing liver, facing kidney, and facing colon. And then we have hilus. Hilus is spelled through it, and outside of it are entering or leaving vessels, arteries and veins. The size of a spleen is about 10 to 13 centimeters in long diameter, and the other are 6 to 8 and 4 centimeters. Important is the length of 13 centimeters. When we have a larger spleen, it's signs that there is something wrong. And because the function of the spleen will be explained, is different, the cause of a large spleen could be also different. The spleen is localized along the axis of 10th rib. And the 10th rib has a very important relation, because when we have injury of a chest and when we observe the fracture of a caudal ribs on the left side, the fracture of a rib could be caused, like a knife, very sharp knife, a cause of injury, of decision of a splenic tissue. And a spleen is richly vascularized, and then the blood could escape directly to the peritoneal cavity, because almost all surface of a spleen is covered by peritoneum. It's developing in a part of dorsal mesentery. In dorsal mesentery of gastric region. So this is seen very well here. Spleen is surrounded by free peritoneal space. Then it's very important that bleeding from spleen is rapid into the peritoneal cavity and could go to the exsanguination and hypovolemic shock. The spleen is fixated by gastrosplenic and splenorenal ligaments. The spleen consists of two kinds of tissue, red and white, like wine, but not wine, pulp. Red pulp is dominating more than 4/5, and it's a sinusoid structure. Sinusoids in a spleen takes about 80 to 150 or 60 micrometers, and this sinus has incomplete basement membrane, and it is in reality is some sponge settled by blood cells, and the sponge is settled by erythrocytes, thrombocytes, lymphocytes, leukocytes, and also macrophages, which ingest spherocytes. Do you know what is spherocyte? Originally, it is an old erythrocyte, which is too old. How long is the life of erythrocyte in general? Who knows?
180.
Too much? 120, about. Yeah, midlife is about 120. So it's easy. This is about 4 months. And then the erythrocytes is not able to take the biconcave shape, and then it's making the inflation, and then there's a balloon-like. And this balloon-like is not able to pass through this sinusoid without destruction. And then this is a cemetery of erythrocytes. Spleen is removing all erythrocytes and the rest of erythrocytes from circulation. White pulp has a different sense. It's localized in periarterial lymphatic sheaths, so along arterioles there is a layer of lymphocytes, and they are forming folliculi. Again, you can hear folliculi, like in tonsils, like in wall and mucosa in intestine, or also in bronchi. So they are forming corpuscula Malpighi, and those Malpighian corpuscula are primarily non-activated. The secondary could be activated during immunity reaction. So immunity reaction could be here. For example, if you have a severe bacterial infection in the abdomen, like typhus abdominalis, abdominal typhus, is a strongly stimulating spleen, and it could occur that the enlargement of the spleen is too rapid and too giant that the spleen itself makes rupture, and the patient could be exsanguinated again due to spontaneous rupture. So because this is a very vascularized organ. So then it's important that enlargement of a spleen could be caused by circulatory disorders, especially some types of anemia, and then immunity caused situations like infections, viral, bacterial, and the third possibility due to neoplastic. So this is a spleen. Spleen, very important organ for immunity and for destruction and the removal of old erythrocytes from circulation. Those three organs, how they are connected? They are connected by portal system. Hoping that you have heard about portal system in a GIT anatomy. Then portal system is a special vascular system containing venous blood, and the venous blood is occurring in a gastrointestinal tube, in a stomach, in a small intestine, in large intestine, but also in a spleen, but also in pancreas, and all those ways are through the portaway into the liver, and through the liver backwards to the inferior vena cava. So all of those structures have veins, and the most important are three radices, roots. One root is a lienal vein. The second is a superior mesenteric vein. They are connected together and they are forming portal vein stem. Lienal vein, superior mesenteric vein. The inferior mesenteric vein voluntarily could go this way, or completely this way. And the fourth important vein that is supplier of the system is seen here. So this is a left gastric vein called also coronary vein. Coronary ventricular vein. The portal vein and portal system could have increased pressure. Increased pressure could be caused by typically diseases of the liver on the level of parenchyma, or on the level of vascular system, or on the level of a overpressure behind the liver. So then we have a very important communications. When the blood is not able to pass through the liver, then it's escaping through the bypasses. Those bypasses are localized here in esophageal region. Those are called esophageal varices. And the bleeding from them is very, very dangerous situation in patients with cirrhosis. The second region is umbilical, which is called caput medusa, head of Medusa. Who was Medusa? if you will read the legend of Perseus, so then you can hear about Medusa who has snakes instead hair. So because it looks like a head with snakes seen on the abdominal wall. So those snakes are enlarged veins, blue veins, formed around the umbilical region. And then this is the case when the umbilical vein is again opened, the ligamento teres rounded ligament is reopened, and the blood is flowing backwards. And the last part is a hemorrhoidal plexus. Probably you have heard about rectum. And in the rectum there are plexuses which could be enlarged, and there is again the communication between caval system, so inferior vena cava, and porta vein, so portocaval anastomosis, important. So now we turn to the second part. So, now we turn to kidney and then adrenal glands and also collecting system of urine. So kidney, in Latin, renum. Kidney is the organ which is primarily localized in the retroperitoneum. It's a retroperitoneal organ which is not covered by peritoneal surface. It's localized in the level of Th12 to L3 with a hilum which is at the level of body of first lumbar vertebra. A right kidney is a little bit lower because of pressure of liver parenchyma. And the upper third to one half of a kidney is touching the surface of the diaphragm, then it could have very important relation to dorsal pleural recessus, which is important in the spread of infection in cases of severe infections of the kidneys. So then we can see in those patients induction of free fluid or also inflammation in the pelvic cavity on the left or right side. So this is the position of a kidney. Position of the kidney inside the retroperitoneum is not directly dorsally from peritoneum, as I said. The peritoneum could be seen here. But then we have several layers of structures will be seen on the next slides. And the kidney is lying in a bed of fatty tissue. The fatty tissue has important reason to be here. One is mechanical protection of the kidney, and the second is, this is something like thermophore. So it's isolating kidney. Kidney itself is an important and the most important source of heat in the human body, in a corpse, because of it is there very high flow of arterial blood and also the processes creating heat here, chemical processes. And it's not too much cooled. Liver is producing also heat, but the cooling with the high flow, with the cold blood, because the major perfusion of liver is from portal vein, it is cooler than the arterial. So then we have the kidney, here is a bare kidney. And the relation of a kidney is then to the adrenal gland, which is in the upper medial pole, and the kidney is lying on this muscle. This muscle is psoas major. On psoas major, the kidney is lying, and along the psoas major, we can observe the outflow tract of the urinary system, collecting system, which is called ureter. So, this is the localization. size and weight of a kidney. Kidney, the size, the long axis is about 12 centimeters and weight is 150 to 180 grams. But we have some pathological situations when the kidney could be a really giant. It could be 25, 30 centimeters long in patients who are suffering from the disease which is called polycystic kidneys, for example. Or on the other side, when the patient has stenosed renal artery or it has some chronic inflammation, the kidney could be then smaller, atrophic, several centimeters. The internal position of a kidney is very, very important to know. Here we have transverse fascia. Transverse fascia is the inner surface of a transverse abdominal muscle and also quadrates and psoas. And this fascia going this way. Here you have one side product which is called fascia renalis, renal fascia, which is splitted into the anterior and dorsal sheath. Anterior sheath is called gerota, the dorsal Zuckerkandel. For German, easy, and for Italy, also Italian, also easy. So Italian, German, renal fascia. The sheath anterior, gerota, dorsal Zuckerkandel. And they both together form sheath, so vagina. So space like a sac in which the kidney is localized. Inside fascia, there are capsulas of a kidney. Outside is a fatty tissue, which is called adipose capsula. It is this thermophore and mechanic protection of a kidney. Then we have the second one. The second one is called capsula fibrosa, dense fibrous tissue covering the renal parenchyma outside and entering also the inner surface of a renal sinus. This space inside is called sinus. Non-empty space filled by fatty tissue, connective tissue, and renal veins, arteries, and also pelvis. The kidney itself is covered by fibrous capsula, which could be dearranged from the renal parenchyma. The kidney has kidney shape, bean-like shape. On the upper pole, medially, is the adrenal gland, which is separated by very thin, splitting fibrous and lipid tissue. Those structures we can then observe. This is the sinus. Sinus is hollow space where we have a vein, artery, and their branches, and collecting system. Collecting system is a dorsal, most dorsal. In the middle is artery and branches, and the anterior part contains vein. So this is a lateral, this is a medial, upper, lower. And the hilum is oriented medially and little bit anteriorly. So this is not in a coronary plane, it's a little bit inclinated towards anterior. In the structures of a kidney, kidney contains two kinds of tissue. Capsula is outside, and below capsula we have a one parenchyma part which is called cortex and columna. Cortex and columna, they are containing glomeruli. And then we have a medulla, which contains mainly tubular system. But here also we have some tubuli. So those are two major parts. Medulla is forming structure like pyramid, so pyramis. Do you know what's originally pyramis word means? Did you heard? This is not the pyramid in Egyptian empire. The pyramis was original name of some special cake of ancient Greeks, and when they saw pyramid, they say, yes, it is pyramid. So pyramid is an ancient 5,000 years old sweet. So this is a pyramid. Pyramid is made from medulla and forming papilla, and on papilla there are small holes which are entering then collecting system. So pyramis and papilla are parts of medulla, and then we have a calyx minor, major, pelvis, and uretero-pelvic junction. So calyces and pelvis are collecting system, and there is a key thing to understand that collecting system and functional parenchyma are separated tissues. They have separated diseases, mostly pronounced in oncology, because we have diseases which are in an international classification. Renal tumors outside pelvis, and then we have renal tumors which are arising from transitional and layering of a collecting system. So those are inner structures. So once again, cortex and columna, pyramid, papilla. Pyramid, papilla, medulla. Kidney is a very difficult to understand how it is developing. It is very complicated. I am not able to explain it because I don't understand to it. But what is important that this complicated development leads to some very common variabilities and anomalous kidneys. The kidney is made from multiple segments of the human body, or somites, and then is condensated, and then is forming those obvious structures. But we have anomalous situations in position, shape, and number of kidneys. The anomaly of position is kidney could be in the region where I have noted, or the kidney could be in a pelvic region. The different position is called dystopic kidney. Dystopia is that the arterial system and venous system arising from different level of aorta or pelvic arteries and veins. Then we have different shapes, because kidney is forming from segments and then it's rotating. Finalization of the shape could be sometimes failing. And then we have the most popular and common, which is called arcuate kidney. But English more frequently use horseshoe kidney. When the lower poles are fused, then we could have also upside down horseshoe, or we have a sigmoid, or we have a rounded discoid kidney, or the kidney could be shifted to the other side, or this way, or also with over rotation, So those are animals. Remember, horseshoe, discoid, and this one forming S, so sigmoid. So now we turn to the key, one of the keys of the medicine, to understand what's the inner structure and function of a kidney. Kidney, this organ, it is a complicated tubular gland, and the production is urine, and urine is created from the blood. It's ultrafiltrate of the blood. Corpusculum renis malpighi, you can see that Malpighianus, Italian physician, has too much names in anatomy and physiology and everywhere. So this corpuscle is made from glomerulus. It's a nodule of arterioles or capillary arterioles. And it has capsula. Glomerulus is called rete mirabile arteriosum according to Malpighi, and they have a pores in endothelium. It has afferent and efferent arteriole. Glomerular capsula has two sheets. One is outside, there's a Bowman sac, from which is then formed proximal tubulus, and the inner sheet, which contains flat cells called podocytes, covering the rete mirabile. This is the major magic structure. Here is created primary urine by ultrafiltration of the blood. This is part of exocrine secretion. Corpusculum renis, forming 200 milliliters of urine a day. We have thousands, millions of them. So then 99 and more % of all production is resolved by tubular system. It's guided by aldosterone for resorption of natrium, and water is guided resorption by antidiuretic hormone. Then we have here this important thing, and from this is important structure from which proximal tubulus is contortus, then is going from cortex to medulla, forming Henle loop, where is resorption of a water made. Here are resorbed other important things, glucose, amino acids, etc., etc. And here is concentrated urine going back to the cortex with the distal tubulus, and from distal tubulus is going to the collecting system, colligans, and then collector, which is leading urine to the papilla and to the real collecting system of a kidney. Then we have also important endocrine secretion, which is in glomerular, juxtaglomerular region. This is here. This is a place where we have the production of hormones. They are important. Renin, angiotensin axis is guiding the proper perfusion pressure. So this is very important in some pathophysiology of a hypertension, blood hypertension. And the second is erythropoietin, because blood could be also guided from the content of the transported oxygen. And when the blood count, red blood count, is too low to support the perfusion of a kidney, it is created erythropoietin, and erythropoietin makes increasing production of erythrocytes in bone marrow. Juxtaglomerular apparatus is a tissue which is between glomerulus and distal tubulus, where is important thing. There we have three important parts: macula densa, mesangial cells, and then juxtaglomerular cells. Juxtaglomerular cells are modified muscles in arteria glomerularis afferens, which is able to maintain the blood flow going into the rete mirabile. And those cells are important for secretion of renin and mesangial, prostaglandins, peptides, etc., etc. Kidney vessels. Kidney vessel, in general, artery and renal vein. The blood is going into the kidney and then is segmented into the interlobar arteries, and they are going into the two pyramids, and between them they are divided in two arteries. This distal artery is called arcuata, forming this arch. And from arcuata we have radiata, radiate arteries, on which they are glomeruli attached. And finally we have some capsular arteries going to capsule. Those radiate arteries bearing glomeruli, but we have different arteries which are entering again the medulla, and those are called arteriola recta and backwards venula recta. They are maintaining the resorption and forming the osmotic pressure here to resorb water back. The arteries in kidney are ending arteries, and we have many variations. The basic are polar arteries, here, here, and here, upper or lower, or we have a doubling arteries, triple, 4, 5, 6, or so 6 arteries could enter the kidney. The variability is too important in surgeries, in kidney transplantation, and also in resection of renal tumors, especially when they are done by laparoscopy or robotic surgery. So this is a blood supply of kidney. Collecting system. Collecting system is a collecting urine which is leaving kidney parenchyma. The first line is calyx. Calyces renalis, renal calyces. Smaller and larger. Smaller are connected to one larger, and then they form a renal pelvis. This is a pelvis, and here you have calyces. Pelvis is localized dorsally from vascular system, and it is very important because for a surgical approach, surgeons, urologists, perform lumbotomy. So surgical approach through the lumbar region. So the collecting system of a kidney forming calyces, calyx minor, calyx major, and then they are connected. Sometimes it could be dendritic, and sometimes it could be less dendritic, and sometimes forming pelvis, which is like ampulla. So then we dividing in general in dendritic and ampullar system. From pelvis is the origin of ureter. It's a following tubular structure which has length about 30 centimeters and a width of 5 to 6 millimeters, so thin, very thin. It has 3 parts. One is abdominal. Abdominal part is from kidney to the crossing iliac veins and arteries, and then it's following to the pelvic part. In the pelvic part, it is going this way, crossing some structures and entering then urinary bladder. And urinary bladder contains portio parietalis intramural part. The muscular layer in ureter outside is a circular and inside is a longitudinal. It's a vice versa than in a gastrointestinal tube. So now we have ureters, and ureters entering the large sac, which is called vesica urinaria, urinary bladder. Urinary bladder is a pear-shaped structure which has 2 ears, ureters, and 1 nose, which is called apex. From apex we have a ligamentum umbilicale medianum, and this ligamentum umbilicale medianum is a dense structure formerly being the connection with the outside space of an embryo, which is called allantois. The capacity of a urinary bladder is about 300 milliliters, and the capacity is enlarging when is dilation of the inner space, and the dilatation is mainly upwards. The urinary bladder itself is localized pre-peritonally, in pre-peritoneal space, but facing peritoneal cavity in the dome and the roof of a urinary bladder. We have here coverage of peritoneal cavity also. We have some approach which is called sectio alta, so section, surgical section directly to the urinary bladder without entering the peritoneal cavity, formerly in medieval and ancient times used for removing a stone from a urinary bladder, and still is used for approach to the urinary bladder when it's not possible through the urethra. So urinary bladder has dorsally and lower 3 points. Those 3 points are ureter enterings, or ureters, 2, and the third is urethra. And this trigonal structure is called trigonum vesicae, trigon, urinary bladder trigon. In between those two, we have interureteric fold, plica interureterica, and behind is recessus, fossa retrotrigonalis. The muscular layer is composed from 3 layers. And in general, inside we have a mucosa which contains transitional epithelium, which is elastic. And also, even it's elastic, it is making folds, because if you could imagine the expansion from 253 milliliters to 300, those folds are then extended, and this is protection to mechanical impairment. Also, very loose connective tissue in a submucosa is protection from mechanical injuries. And then we have a thick muscular layer with 3 layers. 3 layers of a smooth muscle containing detrusor and sphincter, vesice urinaria, sphincter of a urinary bladder. The orientation of fibers is in a spiral manner, forming the very appropriate pressure during contraction. So then outside is tunica adventitia. So adventitia is denser connective tissue, and the roof, we know, that is covered by peritoneum. So you can see that the spiral orientation could be in a different spirals. So this is the arrangement of the muscles. Then we have important outflow from urinary bladder. There is urethra. Urethra is different in a male and female. Naturally longer in male and short in females. The structure is very similar to urinary bladder. Only muscular layer is a small, very thin. Inside is transitional epithelium in upper part. In lower part it is a multi-layered squamous epithelium. And around is periurethrium. In male, the urethra is passing through the prostate, then to the pelvic floor, and then through the penis. In female, it is a little bit different, because there is no prostate and no penile part, so then we have only a short part when the urethra is passing through pelvic floor. Those are those differences. Male, Z-like, with prostate, pelvic floor, penile part. Again here, this is a pelvic floor and outside. Very short. Female urethra, 3 to 4 centimeters short, 8 millimeters in diameter, and it has a very long intramural part which is surrounded by sphincter vesice urinaria, smooth muscle. It has pars pelvina, which is inside and a little bit smaller outside the urinary bladder wall, then perineal, crossing perineal membrane and muscles, and the last part is outside. There, in a perineal part, we have a sphincter urethrae, which has a inner layer, which is a smooth, and outer layer stripped. So voluntary stripped and involuntary part. So this is somewhere in this region. In a male, viral urethra is 20 to 25 centimeters long. It's twice both, and it has 4 parts: intramural, so in crossing the wall of the bladder, then prostatic part, then membranosus, which is in diaphragm of a perineum, and then spongios, because it is going through the spongious body of the penile, and then there we have some enterings. For us, it's very important that we have some important danger points where, when you insert inside urinary tube to catheterize urinary bladder, common, very common medical procedure to protect urination, to protect, to count the outflow of urine. There is here, this is a so-called fossa navicularis, navicular fossa. And the second part is here. They are two critical points where, when improper insertion of a uric tube could make injury of urethra following to bleeding and to scarring. Urethral sphincters in male are more complicated, but in general, in the same manner like in the female, it's complicated more because we have here prostate. So we have a sphincter urethra internus. So this is a smooth. Then externus, which has inner and outer layer, smooth and stripped. And then we have also the muscle, which is seen here. So this is dilatator urethrae. And the last one, muscle, which is an important connection to ductus ejaculatorius, which compressing this, and it's called muscle, ejaculatoris muscle. So last topic, adrenal glands. Adrenal glands are outside those systems. They are part of endocrine system, very close to some neural system. We have two glands which are localized in the upper pose of a renal parenchyma, left and right. Left has different shape than right. Right is V shape and left is epsilon shape, but epsilon upside down. The tissue is formed by two different origins. One is endocrine and one is neuroendocrine. One is originating in endoderma, the second ectoderm. Neuroendocrine part is inside and it is so-called medulla. And endocrine is cortex. The arterial system is supplying the surface of an adrenal gland, and then the blood is going through the several layers, zones, and then going to medulla, from cortex to medulla, and then blood is going to the vein, which is central localized. And we have several zones. Zona glomerulosa, fasciculata, and reticularis. Glomerular zone is producing aldosterone, mineralocorticoid. The fascicular zone, glucocorticoids, cortisol mainly, and the inner layer, which is called reticulata, reticular zone, is producing hormones with some sexual functions, typically masculine functions. So androsterone is one of the leading drugs, products. And the rest, the medulla, is producing something different. Those all hormones are steroid hormones. All of them have those all functions, but mineralocorticoid mainly using dysfunction for minor corticoid, but it could be some effect of glucose and also some sexual. Those products inside are so-called biogenic amines or catecholamines. You know, epinephrine and norepinephrine and also dopamine. Those are products of this medulla. So, once again, cortex, medulla. Cortex, steroids, and here, catecholamines. What's adrenaline and noradrenaline? The same names. We in middle of Europe use adrenaline, noradrenaline. And some of you are from Germany. Germans use also adrenaline, noradrenaline very frequently, but also they use epinephrine. But in our country is not used epinephrine. But in US, some doctors don't know what is adrenaline because they use only epinephrine name. Yeah, the same. Here we have cortex and we have here medulla. So, important. Cortex, corticosteroids. Medulla, catecholamines. Suprarenal vascular supply. Adrenal glands have three sources of arteries. One is suprarenal superior from inferior phrenic artery. The second is originating directly from aorta. It's a medial. And then we have inferior, which is lower, and it's arising typically from renal artery. And there are two different veins, one on the left, one on the right. On the left, we have renal vein, and into the renal vein is drained adrenal gland through the adrenal vein. So on the left, it's not a branch of vena cava. On the right, the drainage is directed to vena cava, inferior. So, and it was solid abdominal organs. Some questions?